I went to Target yesterday, and I forgot my readers. So I came home with fabric softener instead of laundry detergent because they put the fabric softener in the same thing, in the same kind of a container that the laundry detergent comes in. So I get home, I'm like, oh, did we wash? And my husband's like, we still don't have any soap. You were gone for 4 hours and we still don't have any soap. I'm like, we have soap. And I pulled it out like Superwoman. And I'm like, oh. Okay, maybe I said, no, I'll work on laundry tomorrow then. So, healthy coping. All right, illness. This should be a review. Who's it a review for? Acute illness is less than 6 months. Acute pain is what? I thought it was 6. Anything acute is less than 6. Anything chronic is greater than 6. All right, so 6 months is really the kind of the cutoff. It doesn't mean to the day, but around that point it becomes chronic. Now you can have chronic something with remissions and exacerbations, but it's still chronic. You can be in remission where your disease is at bay, you're not suffering signs of it, but we know that it will rear its ugly head again, and we're just kind of waiting for that moment. Okay, go to Socrative.com, room 65525. I could do that $199 ride. No. You know, I went to school with Scott McCormick.
Is that $199ride.com?
Yeah. He hasn't changed.
Want to make out?
Yes. That is disturbing. Okay. Did you guys see it on there? Okay, so the question is, what is it like to be ill from the patient's perspective? I only have 5 brave students. Come on. Patient's perspective, what do you, as a nurse, think it's like to be sick, laying in that bed, from the patient's perspective?
Maybe.
Okay. All right. So we can have devastating, inconvenient. All right, is everybody done? Okay. Devastating, inconvenient. Why is it devastating?
Because it limits you. It can limit you.
It can limit you? Okay, why else? Remember last year when we talked about death and dying? You have to say goodbye to the way things were and say hello to the unknown. A lot of people put down embarrassing. What's embarrassing about it? Okay, so what? Chlamydia is embarrassing. Is it? Oh, I'm sorry. You're saying chlamydia is embarrassing. Tell me more about that. How was it for you?
I have to explain to people what's wrong with you, and
People may not understand.
Yeah, having to explain to people what's wrong with you, and like Kara, and her chlamydia. You know, it's embarrassing to have chlamydia. I don't know, but I would presume it would be very embarrassing to have chlamydia. Because isn't it like a fishy? Doesn't it smell like fish?
I think I got that for you.
Did you get it? All right. Who got the question about chlamydia right and can straighten me out? Is it fishy smelling?
No.
Oh, is that trick? Oh, is that what you get from stool?
Yeah, that's from wearing someone else's wet swimsuit.
Trichomonas?
Yeah.
Oh, I thought that was what you got from like having E. coli and stuff.
All right, if the instructor can't pass the test,
I'm not a mother baby here. I'm not studying this.
come on.
No, I don't do things that come out of there. So, whether it's liquid or anything. If it gets nasty, I'm going to an expert. It ain't right. I'm not crotch worthy. Okay, so it's embarrassing to tell somebody, isn't it? It's a lot of times it's embarrassing because one, you have to talk about things that you're uncomfortable about, even though we're comfortable about hearing it. I love hearing what's wrong with them. I, like hearing and for my own sick curiosity, but really so that they can get better. Yeah, that's where I am. So that we can help them get better. But it is embarrassing talking about some illnesses. It's embarrassing laying there and having people look at you, isn't it? I told you the story about when I had my tubal. Yeah, where I was laying there, open, I turn, I look, I'm completely naked, my boobs are out like this, belt's squirting, and I'm laying there, and there's my friend who we go to dinner with, like hey, well, I'm like, and then I turn and I look, and both of our doors are open, people are walking by, hey, that's baby! All right, so that's embarrassing, although we think nothing of it. It's second nature to us. So can you imagine how a 24-year-old must feel when I come in with 4 female, young, good-looking nursing students? Okay, we're going to put a Foley in today. Just lay back, deep breaths. All right, how embarrassing must that be for them? That whole experience. All right. Isolating. Why would it be isolating? I've just come in with 4 nursing students. Not that you want to see, right. Why is it isolating? A couple people put isolating.
Everyone else likes lives go on without you, and like your friends and your family just keep on living, and you're stuck in the hospital or stuck at home dealing with your symptoms.
Yeah, stuck at home dealing with a chronic illness. Things move on, life goes on. No physical contact if you have chlamydia. Good girl, you did learn something. See, Ashley, I remember that. No, I'm just saying, I remembered. You were the one that said, how come I'm supposed to pass if you can't? Yeah. Funny how that chlamydia just came like right out, like she wanted to say more. Isn't it? Yeah, I think she needs counseling too. That came out way too fast. All right, isolating, embarrassing, depressing, hopelessness. All right, it sucks, yeah. Just want to make it go away. Yeah. So that's how it feels. I think you guys are pretty in tune to how it feels to be sick from the patient's perspective. It doesn't really matter, Kara, because whether it's chlamydia, whether you have chlamydia or whatever, we're going to give you something. So you probably should just take chlamydia. Probably be much. We could make much worse things happen to you. Okay, no. Thank you for giving that perfect example. All right, 5 stages of illness. All right, there's always stages. And in nursing, we like to put things in neat little packages because everything else in nursing we cannot put in a package. All right, so there are 5 stages. The first one is you experience symptoms. Sometimes early enough, sometimes very late, but you experience symptoms. You assume the sick role, whether it's effective or ineffective, and we talked last week about ineffective coping, what that looked like. You make medical contact, whether it is self-referral, referral by a loved one or a family member, you make medical contact. You take a dependent role because you're dependent on others for your care. And then you start the recovery or rehab. You start to recover from the initial or rehab most of the time. There are some people that take the dependent client role and never get to recovery or rehab because they die. But the 5 stages of illness, when there is a recovery or when they do have rehab, these are the 5 stages. Okay. The first stage, the symptoms. All right, so remember the symptoms. Now, thinking back to the talk we had a couple weeks ago, why did I put that picture up there?
Words and pictures of your friend.
Correct. Words and pictures increase retention. Remember that? Student of the day. Yeah. Okay. Because remember with teaching, you're teaching principles. Words and pictures increase your retention. Words by itself is what, like 5%? Picture, 3%, the two of them together, way up, goes way up. Your retention goes way up, all right? So we're going back, teaching principles right there, that slide. Okay. Assumption of the sick role. Words and picture. See, I put a man up there. All right. Medical care and contact. Now, I broke this down because I want to talk about 2 different things. These are the patient needs. When a patient comes in, they want a validation that they have a real illness. And people do not believe that mental illness is a real illness. They say, what do they say? Don't tell me I'm crazy. I'm not crazy. I'm not crazy. You know, it's like going to the mechanic. That back will be rattling for 30 miles getting to the mechanic. The minute you get into the mechanic, it stops. All right? So I go in, first thing I say is, hey, I'm no mechanic and don't call me crazy. But that thing's got to rattle and it just quit. And the first thing they do is like, all right? So people want validation of a real illness. The problem with validating a real illness is one of the things that it's led to is antibiotic overprescription, superbugs. Mothers take their children in for an ear infection, and what do they want? They want some antibiotics. People do not want to leave without medicine. In Europe, they treat ear infections with Sudafed and Tylenol. That's all you get. Sudafed to open it up and drain, and Tylenol for the pain. They do not give antibiotics. Because in America, we want a pill to make this better, and we want validation of a real illness, we now have MRSA, VRE, and the list can go on and on. All right. They want reassurance that they're going to be all right. Most of the time. When would a patient not? Why would a patient, or why did I put maybe there? What? Suicidal. Okay. Why else?
So people go in and don't find out their prognosis is good.
And some people like to be sick. Some people like the sick role.
Isn't that a disease of mental illness? It's called something.
The sick role? Munchausen's? Okay. We'll just break and talk a little bit about Munchausen's. When I worked in Pittsburgh, we had this little boy that always came in and was real sick. And this is before Munchausen's was like a big, now we know, so now we're kind of in tune. You have to remember, I'm going back 30 years. So she kept bringing the child in, and he was always sick. And I mean, from the throes of death, he would be brought back. And they did bring a psychiatrist down for a psychiatric consult, not because they thought that there was a mental illness with the mother or the baby or the child, the son, but because they thought that this has to be really stressful and trying on the mother and the child, because we can't figure out what's going on, and we keep bringing them back and back and back. They keep coming back, and we can't give them any answers. So they went down there to help them cope. So after they got out of that meeting, the psychiatrist said, I want to know if they come back in, please consult me when they come back in. So sure enough, they came back in, and they set up cameras in the room. Because he said now you couldn't do that. Now there'd be an invasion of privacy and everything. But back 30 years ago, remember, we used to posy people down with 4 posies to the bed. So they put cameras up in the room because he then said there's this disease, Munchausen's by proxy. Munchausen's is when someone does it to themselves for the attention of others, the medical personnel. Munchausen's by proxy is when someone does it to someone else to fill their needs. And sure enough, they caught her injecting the child with her own feces. She would put it in a syringe, dirty needle, liquid it, mix it liquid, and inject it into him. If he had an IV, it was going in IV. If not, she would do it IM. And that's what Munchausen's by proxy is. Now people do insulin. They'll tend to give people extra insulin or withhold their insulin or whatever, because some people like the attention. Because what happens when you're sick? People, like we talked about, people come, they bring you dinner, they're nice to you, they clean the house, you get all this attention. So you have, it meets an unmet need that you have. So, reassurance that they will be all right. But most people, by and large, want reassurance that they're going to be all right. And they want a prediction of the outcome. When's this going to leave? How long am I going to be sick? Am I going to be cured? Am I going to die? That's what patients need. Validation, reassurance, and prediction. What they hear is you're going to be fine or you're going to die. And not necessarily at the right time. They might hear, the doctor may say, most people, the survival from this is very low. Only about 5% survive. So what are they going to hear? Oh, I'm going to be fine. Yeah, I'll be fine. When most people would say, it's probably not looking good for me. Some people will hear, 5%. Oh, yeah, there's going to be a chance. And some people will hear, when we say, yeah, you know what, it's just chlamydia. You take this medicine, you'll be fine. Others will hear, I'm never going to have a baby. I'm going to die. This thing's going to go into my blood. It's the end of the rope for me. Or people get sicker. They become sicker than they actually are. Have you ever known someone, it's like, it's a hangnail. It's not death. It's a hangnail, for crying out loud. You'll be fine. Give it a couple days. It's the flu. My husband, you would think. When I went away in January for a week with my sisters and my mother, he was ill. The whole place fell apart because he was ill. Couldn't get out of bed to even stop the partying or anything like that. So, and unfortunately, my boys know this, so they're like, "Oh, he's not getting out until he's 100%." We got this house for like a week. All right, go back to soccer tip.
Lordy.
That's my husband at the beach.
Yeah, you even offer a Zoom option on there, thank you. At least it's big enough on my screen.
Did you go? All right, you guys answer the question. Quit clicking on the guy in the show.
Don't even get a closer look.
What? You need a bikini wax? Is that what you got on Zoom? I'd like to see what the back looks like. That has got to be horrible.
Probably really hairy.
It's back. Well, no, I just wanted to know how high up that thing has gone.
That doesn't scream infection. That's somebody else's wet, whatever that is. What is that called?
What's what called?
Hanging has on.
I think it's just a bikini, but like a Speedo,
Like a banana hammock.
and then he pulled up onto his shoulders.
Nuh-uh.
No,
I think
it's
they
actually
make
a
them like
suit
that.
of some
No,
sort.
that's,
They sell those at Walmart. Yeah, they
you ever
sell.
seen a
I'm just
Borat?
kidding. Hold on, I'm doing.
Borat? Why?
Go on YouTube and look up Borat.
Is this what Borat wears?
Yeah.
That's,
That is
isn't that
Borat.
Borat?
Is this Borat?
Yeah.
Borat at the beach? Oh.
Don't Google bikinis for men.
Bikinis for men?
Don't do it. Especially
Do
not-
it.
Yeah, don't do it.
You know you want to.
I do want to. I do want to, but I'm not going to. Okay.
She's gonna do it later. She'll do it on her own time. That's it.
Oh no, I'll probably make I'll end up making something like in first semester during skin disorders. I could do what red groins look like. This is what gives you red groins, so I could show the bikini things. Got it.
See, you knew she was gonna go there.
Yeah, it's all yeah, right. I know, but at least I have a professional reason to do it.
Yeah, a good
Do that
excuse.
first semester.
Yeah, I'm gonna do that. I'll
Just
just-
do a whole slide of all men's bikini areas.
This is what causes yeast infection. Name that yeast infection. You know, my cousin is the diaper designer for Huggies. And she got to, now she's a project manager. So when Huggies first decided to do the swim diapers, they call them swimmers. She, you know, there's a thing in there, they call it, is it like stool fallout? Fecal fallout? And what they do is they have people poop, and then, you know, they have a bowel movement, they wipe, they clean up. And then they put their underwear on, and then when they take their underwear off, like at the end of the day, or whatever, they have to wear that underwear for like 12 to 24 hours after they have their bowel movement. And then they put it in a bag, and they bring their bags to Kimberly Clark down in Neenah, and then they see how much poop fecal material is on the underwear. You with me?
Yeah.
So there are researchers that actually research this because they want to determine how much of the fecal material will be on that swim diaper. So how much of that fecal material is going to get into the water? So they can say protects whatever, from entering the water. How'd you like that to be your job? They do the same thing with periods. How they do that? They have women, and then you keep your tampons and keep a log of how long you kept this in, and then you take it down to the research and development department at Kimberly-Clark, and then they do the research on how much it's sopped up.
Do you get paid for your interviews?
Yeah, you do.
Same question.
Yeah, you do. A lot. I worked at Kimberly-Clark for a year and a half, and they always want before they iron out all the details of the study, they always want employees to participate. Okay.
So how much fecal material did you contribute now?
Not telling. But see, they can't use they use employees to work out the details, but they can't use employees for the actual numbers because it may be skewed. But what the nice thing about working there was they had a product room where if anything, say for instance, I don't know, there was any deficit or any defect in any of the materials, or they had to open up like every 12th case and check for quality control. They took all those tampons, pads, diapers, and everything and put them in the product room, and you could go in and get free products. So like for a year and a half, I never paid for anything. Yeah. So that was a nice perk for keeping my underwear in a bag overnight. Okay. So what does maladaption look like? It looks like denial. Yep. Isolate themselves. Ooh, why do people isolate themselves?
I don't know, maybe depending on their illness, they're worried that they're gonna get other people sick.
Might get other people sick. Don't want people.
Maybe it'll go away.
Yeah. They don't think about it, talk about it, maybe it'll go away. Yeah. And we know that's maladaption. Needy? Oh, what's needy? What's needy? Tell me what does needy look like?
Can't do anything on their own.
Can't do anything on your own. Always on the call button, right? Why do you suppose people are always on the call button?
Because they're
What? Lonely? Anxious?
Want to make sure if they push the button, somebody's really going to respond.
Yep. We were just talking about that being intubated, and I said if I were ever intubated and awake, I would take the call button, I would take the string, wrap it up in my hand, and I would not ring the bell. I would pull it so that it comes out of the wall and immediately initiates the code. Because I would want people to come to my room. I don't know that I could do it. I really don't know that I could be have an awake intubation or be intubated and be awake. You would have to put me out. Mainly because I've seen too many whoops. Oh, that was lucky. All right. Why else are people needy?
Try to make the best of what they have left.
Try to make the best of what they have left. They want to start making demands on people because it may be more than it is. Mm-hmm. There was a study, this woman had come into a nursing home, and she was on the call light. Essentially, when they did it, it was like 25 to 30 times an hour throughout the entire day, pressing the call light button, just like that. And her light was always on. And, you can't run a nurse, you can't be a nurse or a CNA anywhere and have someone on the call light that much. So what they decided to do was they made purposeful rounds. They went in first every 10 minutes. and just checked, even if she didn't need anything, even if she didn't have her call light on. So first they had to wait till a period where she didn't have her call light on, so kind of like Pavlov's dog, which is what kind of learning theory? Behavioralism, right. So they're trying to change her behavior. So she, when her light wasn't on, someone popped in. Hey, how you doing? You okay? Anything I can get for you? Would you like anything? And then the times started to gradually increase from the time she had on her button until toward when they were done. Then they increased it to every hour they popped in. And she was on the call button maybe once every 8 hours. Because now we had changed her behavior, she knew what to expect, and people were in. So sometimes if you have someone that's really anxious or on the call light a lot, try to pop in and see what they're doing. Change their behavior. Change the behavior to the desired behavior through behavioralism. Okay, good. Not accepting that you're sick, not resting. Okay, yep, going out, doing more. A lot of people push themselves, don't follow the instructions, making more of it than it really is. So people have a vast expanse of coping mechanisms, and maladaptation looks different from being needy to not contacting anybody at all. So it comes in many different forms, shapes, and forms. So we have to be cognizant that it won't look, one size won't fit all. All right. Okay, dependent client role. Now, the aspects of being sick. The aspects of being sick are, this is what being sick does for most people. They're excused from social roles and tasks, fills an unmet need for some in maladaptation. Maladaptive coping is forgiven, because what do we say if someone's rude and snarky?
I just don't feel good.
Yeah, she doesn't care. She's sick. She's dying. Be over in a few months. Okay? They're not held responsible for their condition. All right? She can't help it. She's sick. So maladaptation and being sick might look like this when it's maladaptation. All right. Responding to this dependency. First of all, you have to recognize what's happening. Oftentimes, people who are maladapting to disease will make appointments for stuff that they could take care of themselves. My dad, before he goes on a big trip, always has to go to the doctor. Like, I gotta get checked out and make sure everything's okay. I said, Dad, that's what you do with your car, not you. Just take your car to the thing, get an oil change, make sure it's tuned up. But you don't have to go. But he always has to go. Get a checkup, make sure he's okay. Going up for the weekend. See the doctor, make sure I'm okay for this. All right? That's maladaptation. He doesn't need to see the doctor. They'll come in, they bring excessive gifts. Hey, just dropping by, I thought I'd bring you guys this. My wife baked some bread, I thought I'd bring you this. Now, a gift once in a while is fine, but when someone consistently comes and brings you gifts, why do you think someone would bring you a gift all the time, bring the office a gift all the time?
Make sure that family member is being treated well or maybe better than the other patient.
Right. Making sure that they're being treated better than the others. Or when they call, they get some service. That's what they want. All right. They won't see another doctor, even if their doctor's away. No. I will wait for my doctor. Or I would like my doctor's phone number. That's okay, I'll just call my doctor. Most doctors sometimes will give their phone number, personal phone number out to patients when they're dying and on hospice, but they don't give their number out when, or they should not, and you should not give your number out when the patient's not dead and dying. And really, the physician can't do anything anyway when the patient's dead and not, dying in hospice. But sometimes patients feel better. But don't give your name out to patients. Why not? Other than they'll bug you. But what are the legal ramifications?
I could say that you gave them, you told them to do this and that's, they followed what you said even though you may not have.
Right. And you don't have any paper trail for that, so you have to watch that. The other thing is they may need emergency help, but they keep calling you. They're gonna try to get a hold of you, and they can't get a hold of you. I thought that I would just wait until I got a hold of so-and-so, and it may be something that needs to be treated right away. Inappropriate positive feedback. What would that look like? What would that look like? How will you know when that happens to you?
Bueller. Like as a nurse or a patient?
As a nurse, how will you know when that happens? Somebody comes into the office, how will you know when that happens? Inappropriate positive feedback. What's inappropriate positive feedback? What does it look like when you're a nurse?
Like flattery?
Inappropriate positive feedback. Tell me what it would look like. What is it? What does it sound like? Well,
Maybe them bringing you like a gift card because you gave them their test results or something.
You are the best nurse ever.
right. I would not be here today if it weren't for you. Now, people will say that, and that's fine. Inappropriate positive feedback is, I would love to be married to you. From a 98-year-old guy. No, I would love, I could make you so happy. You're so beautiful. You're such a cool person, such a neat guy. I could make you really happy. You deserve more. I would not. If you married me, if you stayed with me or slept with me, I would not make you work this hard.
Oh my.
Yeah, he's like, where do I find one of these guys?
No. It's running the other way.
All right. Genuine symptoms without any identifiable pathology or etiology, especially after extensive examinations or testing. People do this. There are some people that come in all the time. I know there's something wrong with me. They want the full gamut run. And instead of saying stop, we keep, enough is enough. We keep giving it to them. More and more and more, and do more and more tests, because there's going to be one person that we didn't do the test on, and they ended up with a curable form of cancer that we caught too late. That's why we do it. All right, rehab and recovery, acute illness. Acute illness, you usually find it pretty easy to return. It may take a couple of days to get back to normal. Chronic illness, more difficult. Permanent disability, the patient must learn the adjustments that are necessary for optimal functioning. Effects of illness. All right, what do you think? Take up your Socrative. All right. Which of the following effects of illness is the most difficult on the patient? No, it's just the worst. Which do you think would be the worst for a patient? 22, come on, 23. Oh, did all you guys fill in your survey that I resent the link? Advisor feedback. If you think about it, do it. All right, ready? How'd we do? Lifestyle changes. So most people felt that lifestyle changes are the most difficult on the patient. I would have thought financial. That's what I would have chosen as the financial changes. But why lifestyle changes?
Because if you're used to being out and, being out with people and being a very social person, and now you may have an illness that prevents that.
Okay.
So you used to be outgoing, but now you're no longer outgoing because of your illness.
Okay.
You can't eat like you used to.
You can't be like you used to.
Can't eat like you used to or something like that. My dad's going through that now.
Is he
He's,
going
like,
through that now?
not eating sugars and stuff, and it's really hard for him to.
Yeah.
I can see why.
Yeah. Because it's a change of from what you did. And most people like their lives, like what they used to do. It's hard to change, isn't it? We talked about that under lifestyle modification, that it's hard to change. Behavioral change is hard. So lifestyle changes, that's that whole adjustment. Financial changes or financial demands, why not financial demands? Why do more people pick financial demands? Credit cards? It's eventually going to catch up with you. What else?
You or your kids.
Yeah.
It's a young group.
What?
It's a young group.
It's a young group.
If this were an older group, we'd have more people pay financial.
And maybe because they're students, they're not used to anything yet, much yet.
And maybe it's just that it's not something that you think about all the time, where if you have to change your lifestyle, that's every single day, not just the day that the bill comes in the mail.
Mm-hmm. Right. You only have to think about that bill when it comes.
Mm-hmm.
Yeah. Adjustment to the new role. Back in my day, adjustment to the new role was a big thing, because the men went out to work and the women were teachers, secretaries, or nurses. And that was it. And not many women worked. My mother was a Phi Ed teacher, and she was a trailblazer because she worked. She had her own income, and she worked. But when she went for her first job, my dad was a biology teacher, and the two of them went to a place, I don't know if it was Moses, it was somewhere around in here, and they offered my dad salary, what he normally should have gotten, and then they offered my mom a job for half of that. And she said, well, why? And I said, because you don't need that much money, your husband's working. So it was like that for women for a while. So the adjustment to a new role, having a man sick or having the woman sick, and now the man having to care for her, that was tough. Those were really tough. And finances. No one wanted anyone to care for them financially. Everybody wanted to be very financially stable. My parents right now, when I switched my first job, my parents were in their same job until, I don't think, my mother had a teaching job at Amherst until she met my father and married, and then they went and they got their teaching job, and they stayed in that job. Never left, never went anywhere. So I had my job. I knew my job at Kimberly Clark was going to be short term because I was in love and I was going to be moving with wherever this guy moved. So I was like, when I left my job, you'd have thought, he was like despondent, like, I'll give up a good job. And even my mother-in-law was like, oh, she must really love him. She gave up a really good job. And I'm like, tell it doesn't. I'm a nurse. I can go anywhere. And that was not something you did. So it was very concerning. All right, we'll see what that's like in another 20, 30 years. All right, now we're going to talk about children coping with illness. Separation anxiety is the big thing. It's a normal developmental stage for infants and toddlers. They have a regression behaviors in older children often occur. And what does that mean?
But if they're potty trained, they may not, they may go back to it.
Right, right. They regress backwards. So if they were once potty trained, now all of a sudden they're wetting the bed. All right. If they didn't drink from the bottle, now all of a sudden they can't drink from a sippy cup. They want a bottle. That happens. All right. If someone close is unable to stay with the child during hospitalization, the child is likely to go through the three stages of separation anxiety. And the stages of separation anxiety: protest, denial, and then detachment. And detachment is very tough for parents. Do not perpetuate the bond that you have with the child, because the child will come and cling on the nurse, cling on you. I love you. I want her to be my mommy. All right? You're not their mommy. Their mom is their mom, and the mom needs to go back. Remember, it's not anything that's happening probably in the child's life. It's the stages of separation anxiety. So encourage, and sometimes mothers, they can't be there all the time, especially children with chronic illness. You don't know where you're going to be working. You may have a child who has leukemia or something, and the parent has to go back home and take care of the 5 other kids, get the house straightened out, and then be able to come back. So encourage that child, that you talk about the child's mother, talk about the child's father, their family, that they're coming back, that they're going. So encourage that so they know that you are not their mommy. If they call you mommy or daddy, you say, honey, I'm not your daddy. I like you a lot. You mean a lot to me. Hey, I'm not your daddy. Your daddy will be coming whenever or whatever happened. But don't make it harder for the parent than it already is, especially parents with chronic illness, with the children with chronic illnesses that are trying to maintain 2 homes and keeping care of 2 families. All right. A system, social services, make the family comfortable, try to adhere to the child's normal routine, involve the parent in the care, teach them how to care for the child. Hospitalization in the elderly. Now we go from one extreme to the other, don't we? All right. What you want to do with elderly is to protect their health so that they can go to their prior living situation. Now, we know that that's not all the time possible, but that is what we have in mind. That's the goal we have in mind, to try to get them home. So we don't want them to sit in the hospital doing nothing, because we know that it's going to take longer for them to return to their optimal function so that they can maintain in their home. They can maintain safely in their home. Prevent nosocomial infections. How do we do that? Hand washing. What else? What? Not leaving in Foley's, right? Indwelling catheters, get them out. What else?
Gowns, gloves.
What?
Gowns, gloves.
When necessary, yep, follow precautions.
Septic.
Yep. Aseptic technique. What else? Mouth care, personal hygiene. They need baths. The chlorhexate pads work better than soap and water. So if you have those and you're like, ugh, I think these are weird, they work. They actually prevent infection better than soap and water does. They need a bath daily. They need oral care. If somebody's mouth breather, unconscious, they need oral care. That's how you help prevent infections in adults. When you put in a central line, maintain sterile technique. All right. Prevent issues that slow therapy. What are some issues that would slow therapy? Fall, pain, right? Pain. You should be cognizant of pain control. What else? Pain control, pain medicine before therapy. Don't give Lasix before they're going to therapy. Don't give them their bath and make them have breakfast and run them and do all your stuff before they're supposed to go to therapy because they're going to be exhausted. Try to time it with therapy. Get them up to the chair, back to bed. So keep them moving, have them move so that you don't decrease the function that they have. Assess for undiagnosed problems and prevent complications from diseases. All right. Prevent nosocomial infections. National Guideline Clearinghouse tells you exactly what you are supposed to do and what measures your organization is supposed to have in place to prevent these infections. You should look at those and know those. Issues that prevent confusion, sleepiness, dehydration, decreased nutrition. All right. Undiagnosed problems in the elderly. Depression, big problem. There's a depression scale, elderly depression scale you should look at. Drug, alcohol, vision, hearing, self-care, and nutrition. Stopping pressure ulcers, you gotta keep them moving. All right. We're gonna talk about stress. So you guys probably know about this because it's probably been that today. Stress and the stressor. 2 exams the same day, right? Sources, internal, external, developmental, situational. You can read this. Effects of stress. How does stress affect you physically? Makes you fat how? Makes you eat unhealthy, all right? Makes you eat more, makes you eat things that you normally would not have eaten. Why do you think you do that, Kara?
Honestly, I sit when I study, I sit and eat. I feel like, I don't know, it keeps me awake
Keeps you awake, right. It keeps me awake too.
to eat.
Yeah.
It's terrible.
Uh-huh. I don't like the Red Bull, but I love, a bag of chips. Be fine. I'll be up hours. Yeah, cappuccino, second on them. Okay. Emotionally, what does stress do to you emotionally? Dreams? Drains you, makes you more tired. What does it do? Makes you cry, sad, feel sad, irritable. Yeah, right. Irrational. Right, not thinking clearly. Intellectually, what does it do? Yeah, it's harder to think when you're stressed, intellectually. Now, some people will say I do my best work when I'm stressed. I write my best paper. Marlene does this all the time. She drives me crazy. I'm going home tonight. I'm like, hey, you want to go out and get something afterwards? She's like, oh no, I got to write a paper and have it in. I go, oh, like by when? Like when? She's like, oh, like 8 o'clock tonight. It's like 6. I'm like, really? She's like, yeah, I got to go home and see what the topic is. Oh my God. Okay. He's like, I do my best work when I'm under the gun. All right. Maybe she does, but some people can let things go, but they don't bring in all the other things that can be. Socially, how does stress affect you socially? Right, you have no social life.
I had tried getting that and it's because I wouldn't come down to the bonfire and play badminton. I need to have to work and study.
Yeah.
That's not me right now. I'm like, oh, it's
Not really a friend. Cross her off your Facebook list. Yeah, right. You're stressed. You forgot what you're going to say. It doesn't stay in your mind very long. All right. The other thing that we need to talk about is the difference between empathy and sympathy. All right. So empathy is the power of understanding and imaginatively entering the other person's feelings. Identify with and understand the situation, the feeling, and the motive. Remember, it's understanding. Now, sympathy, on the other hand, he made the saddest face he could possibly make, and still no one would agree to sleep with him. All right? So sympathy would be, all right, I'll sleep with you.
That is rather good.
All right, because so you take on that other person's feelings and problems, all right? This guy didn't feel good, so someone's got to sleep with him to make him feel better. All right, so I'll sleep with him to make him feel better. All right, that is sympathy. Empathy is, poor guy. It's got to be tough not to be having sex. Maybe I'll tell him a haircut would help. All right, or something else. All right, but I'm not going to sleep with him. Sleeping with him is sympathy. Saying, oh, it's got to be tough. That's empathy. Sympathy will burn you out. Empathy will keep you going. Empathy is compassion. You're looking at me like this. Why are you confused?
Because I was understanding that differently, like opposite.
Okay.
The way you're describing it.
How are you thinking?
That empathy, there was this big study they did in England, changed the model and they're stopping teaching empathy in nursing school because it causes burnout. And they're switching to a compassion model. Because it's not trying to put yourself in someone's position, but seeing their suffering and giving a crap is different than.
Yeah, then what is your then what would the definition of sympathy be?
That's how I would put sympathy more in the realm of compassion than empathy. I guess.
I empathize. Empathy is more of compassion. That'll be interesting. I'll look up the definitions and see if some things are changed. But it's really empathy. Being empathic and compassionate. Sympathy, being sympathetic, is generally, taking on someone's. I have a deep sympathy for that person. Are you looking up the definition? Pity, yeah. Pity is more, I would think, more sympathy. Empathy is,
For sympathy, it says feelings of pity and sorrow for someone else's misfortune.
okay,
And for empathy, it says the ability to understand and share the feelings of another.
yeah. So empathy and share these feelings, like I have this. I don't know what I don't know what the difference between empathy and what's compassion mean?
Sympathetic pity and concern for the suffering or misfortunes of others.
What's compassion?
Sympathetic.
What,
She just read it.
oh, is that what you read?
Yeah.
The sympathy for others?
It's sympathetic pity and concern for the sufferings or misfortunes of others. That's what came up for
Alright,
sympathetic.
well, I'm all screwed up there.
This one is sympathy is having compassion, but you don't feel that person's feelings, and empathy is you share or you can feel that person's
That's what that says in empathy versus sympathy?
We have empathy is where you can be sad with them or be happy with them, whereas sympathy is more on the outside, oh, I see you being sad and I acknowledge that you're sad. Okay, you're sad. That's all you do about it.
Feel sad for
But
them.
you don't feel sad for them. You're just okay, I see that you're sad.
That you have sympathy.
Okay.
Feeling their pain.
Not feeling their pain. So you think feeling their, does anybody have their cozy or nerve? Do you have, yeah, anyone calm? Oh, cozy or, Annie, can you look up, see if in your med surg book, see if empathy is in there? Did you keep that article, John?
No, I work at the library. I read one article.
Oh, John. I don't believe it, John.
Yes.
They were part of it on Monday.
Yeah.
No.
Is it in there?
Nope. She has the quiz yearbook.
Oh, you do? Okay, so she'll look that up. Okay, and then we'll come back to sympathy and empathy. All right, shame. What?
So if we can't get it straight, then we won't be able to.
Right, if you take it back. No, so I'll have to look that up again, but, all right, so thanks Yeah, thanks for bringing that to my attention. We'll talk about it. We're gonna talk, I wanna show you this right now before we go. There's a few other things after here. This is Dr. Brene Brown. She is my favorite social researcher. And I really encourage you to, she has a lot of TED Talks out. She does a lot on shame and vulnerability. How she identifies vulnerability, I think, is very close to what patients feel. And how we deal with vulnerability, I think, is very important. I know that since I have been following her a lot, and she has a few books out too, that my view of people and the human condition is a little bit different now. And the way that I work through patients and work with patients and move through this is a little bit different now because of her vulnerability and shame, and shame talks. So I'm going to show you this. I have a couple other of her TED Talk or of her other things. I encourage you to look at it. But right now, we're going to do shame.
They say after seeing a magician make his assistant disappear, Mr. Clean came up with a product that makes dirt virtually disappear. He called it the Magic Eraser. It cleans like magic. Even baked on dirt disappears right before your eyes. Mr. Clean's Magic Eraser.
In her second book, The Gifts of Imperfection, Brene says we need to look before we take the vulnerability leap and choose carefully who we open up to. So I love in Gifts of Imperfection where you say, if we share a shame story with the wrong person, they can easily become one more piece of flying debris, so well said, in an already dangerous storm. We want solid connection in a situation like this, something akin to a sturdy tree firmly planted in the ground. We definitely want to avoid the following. The friend who hears the story and actually feels shame for you, she gasps and confirms how horrified you should be, then there's awkward silence.
Oh, yeah.
Then you have to make her feel better.
Oh, yeah.
Yeah.
Have you ever had that happen?
Oh, my goodness. Where you're like, yeah.
Oh,
so
God.
now you have to now put your shingle out for that person. Yeah.
Yeah, now I'm still in shame, and I'm one less friend down. I'm like, and you're gone.
The friend who responds with sympathy, I feel so sorry for you, rather than empathy. I get it, I feel with you, and I've been there. If you want to see a shame cyclone turn deadly, throw one of these at it. Oh, you poor thing. Yes. Or the incredibly passive-aggressive Southern version of sympathy. I love this. Bless your heart. Yes.
That gives me the shivers when you say that. That's
Yes.
like, I'm fixing to tear you down, and God is on my side.
Yeah.
It is the worst.
We've all been there. The friend who needs you to be the pillar of worthiness and authenticity, she can't help because she's too disappointed in your imperfections because you've let her down. Yes.
Painful.
The friend who is so uncomfortable with vulnerability that she scolds, how did you let this happen? The friend who's all about making it better and out of her own discomfort refuses to acknowledge that you can actually be crazy and make terrible choices. You're exaggerating, the person says. It wasn't that bad.
Right.
Yes. And the friend who confuses connection with the opportunity to one-up you. Well, that's nothing. Listen to what happened to me. So when you open yourself up and you're vulnerable enough to share something that has shamed you, what are you really looking for?
I'm looking for the person who loves me, not despite my vulnerability and imperfection, but because of it. I'm looking for what I call my move the body friends. I'm looking for the folks who are going to show up and wade through the deep with me.
Mm-hmm.
And I think it's a myth that you should have more than one or two of those. You know, the TV commercials that show 15 of us laughing and doing that kind of stuff, You got one person in your life who you can call and say, I just told a bold-faced lie to someone I care about and I have no way to get out of it, and I'm in a shame storm of epic proportion. You have one person that look at you and say, all right, let's do this thing.
Mm-hmm.
I'm with you. I've done it. Let's talk it through. You are so lucky.
And if you have two or three, that's
Forget
it. Forget it. Lottery.
Yeah, and you know what we all do, myself included, is we steamroll over those people to get the attention and appreciation of the people who will never show up for us like that.
Wow.
So like, you know, you may be my best friend and you might be all around me all the time, but those folks, those women at the mall that I don't know, they're the ones I'm really worried about.
Yeah. trying to please or prove
Right.
yourself to them. And you say, of course, we're all capable of being these friends.
Yes.
But especially if someone tells us a story that gets right up in our own shame, that's when it hits the nerve, right? We're human, imperfect, and vulnerable.
Yeah.
Yes. It's hard to practice compassion when we're struggling with our own authenticity or when our own worthiness is off balance.
And you know what means the most to me? What means the most to me is if I go to someone with my shame story. And my whole mantra is, you share with people who've earned the right to hear your story.
Damn, that is good.
Right?
Doggone it,
Like,
that's so
you have
good.
to earn the right to hear my story. It's an honor to hold space for me when I'm in shame. And so I want to share. And if I share with someone...
We need to just pause with that for a moment. Okay. Because this is how people get so messed up and violated. It's like the Bible says, casting your pearls before swine.
It's
you
true.
know, offering yourself up to people who don't deserve to have that offering.
That's right. And you have to think long and hard about who has earned the right to hear the story and with whom am I in a relationship that can bear the weight of the story.
Wow, that is powerful.
And if I go to someone and I share it and they come back with one of those bad, like not helpful, not empathic answers, and then a week later, a day later, an hour later, they call and say, I didn't show up for you. You were so much in my stuff. I couldn't be with you in that. That means even more to me. We're not going to do empathy perfectly. You know, we're not going to have the right response every time.
Yeah.
Does that make sense?
It does. It's so overwhelmingly powerful.
Okay. Why would I show that? What? Huh? Why would I show that? How does this relate to caring for patients?
Because people may want to share their issues.
Mm-hmm.
A lot of times it's hard not to be judgmental.
Yeah. They may want to share themselves, tell you their shame story. Remember, we are the most trusted profession. So they share their shame story. And when they share their shame story with you, it's a lot of times some of these are not pretty. A lot of these are not pretty. But when they share their shame story, will you show up for them? And that's what you have to decide. Will you show up for them? And she talked about the things not to say to people. Oh, honey, that's not so bad. Listen to what I did. Right? How does that make you feel when somebody says that to you?
Like your problem is not very important.
Right, like my problem's not very important. Although the person saying it may say, oh, either they like to hear themselves talk or trying to make you feel like it's not that bad. It's bad. It's bad to the person who's saying it. It's their shame. That's their shame story. It's bad for them. If someone says, how did you let that happen? Is it important? Is that important? I find myself as a mother saying, how did you let that happen? Really? That's not what's important here. I don't need any more guilt as a child or a patient than I already have. This is my story. Don't give me judgment. Oh, you poor thing. What did she say, though? What should your response be?
Let's talk it out.
Yep. Okay. Let's talk this thing out. That's what you say. Let's talk this thing out. Let's work this out. Because if I say to you, let's talk this out or let's work this out, how does that make you feel? Like it's going to be okay. Like okay. And when you went and we did the Socrative before, we talked about what's it like to be ill. What's it like? What does maladaptation look like? What did we say? Hopelessness. All right, being alone. But when I say, okay, let's talk this out. Does that make you feel hopeless? Does that make you feel alone? No, it starts to change. The whole thing starts to change. your patient starts to change. So remember that, and you have to be open to it. So don't, when someone tells you their shame story, says, listen, I got to tell you something. You know what? It is time to sit down. It's time to sit down, take a load off your mind, and listen to what they have to say. And listen to their story. And if you can't, and you don't have time, and you absolutely cannot make time, then you need to tell them, I want to give you my full attention. Let me take care of a few things, and I will be back in a half an hour. And then you show up in a half an hour. Because being ill, being sick, comes with it a whole bunch of baggage. And you're going to get it all. It's how you handle it that will separate you from the mediocre to the truly helpful. Right? Any questions about that? I encourage you to go to Brene Brown. You just have to Google her, and you'll find a couple other talks. Her vulnerability talk is really good about being vulnerable. And when people tell you these things, you have to remember, even though you may not want to hear it, they're telling you this, they are at their most vulnerable. And how does vulnerability feel? Kara, how did you feel when we started talking about chlamydia? Even though we knew it wasn't you, but it was like, oh my, I got this big thing out there. A little anxious maybe? Like, stop. I wish this would all just stop. Right? Because I'm vulnerable. That's what vulnerability feels like. It feels horrible. So it's your responsibility to be there for that vulnerability and realize that when someone shares their shame or their vulnerability with you, that's one of the greatest compliments you can have. It's one of the greatest gifts you're going to get from that person, but you have to treat it like it's fine crystal. Because if somebody tells you your shame story and your pager goes off, oh, I gotta go, and you leave right there and they have just given you every bit that they've been holding for years, that's not going to be good. You turn that thing off, or you say, I will be right back, and you go and give it to somebody else and you come back in that room. Okay. We have a question on the questionnaire whenever someone's admitted, are you safe at home? What if somebody says, no, I'm not? You got to close the door, you got to give your pager to somebody else, and you got to sit down. Because you may be the only person that's going to help that person right then. The only person they have let help them. And you got to take care of it right then. Okay. Coping is a definition. Coping strategies, avoidance. You can avoid the problem altogether. Problem focused or emotion focused. Usually we're somewhere in between. I'd like to be problem focused, but usually there's a little emotion, a little avoidance. Coping mechanisms, either destructive or destructive. Adaptive or maladaptive. Ineffective coping strategies, you can look at those. Effective coping strategies. Definitions, the what ifs. What ifs will kill you. What ifs will kill your patients. There are no what ifs. It's what is. What ifs will kill you. What if I, what if I, what if I, what if I. I'm a what if. Defense mechanisms and maturity. Projection, least mature to the most mature. Types of defense mechanisms, you're going to want to look at these and know these. You may have to make flashcards, look something. Nursing diagnoses, 4, stress, adaptation, and coping. These are your nursing diagnoses. Here's another on vulnerability. Courage is to tell the story of who you are with your whole heart. That is the definition of courage. This is the vulnerability TED Talk that I talked about. Therapeutic communication. This is a review from first semester. False reassurance. Do not give false reassurance. Because when it doesn't come true, how is your trust? There is none. Do not give false reassurance. You could say, yeah, this is tough. It's going to be tough, I agree. Or tell me how you're feeling about it. Tell me what you're thinking. Don't add your personal feelings, just tell me what you're thinking. All right, the angry patient. Anger is an emotion. People have the ability and have the right to be angry. When you have a patient who's angry, protect yourself first and then others around you. Don't try to reason with them. Don't tell them they're wrong, because that's not going to work out. Mediating anger. Help the patient own their anger, but I would not do that in the acute phase. Ask what contributed. What happened? Tell me what happened. Try to understand the meaning of the true anger. What is this about? Where is this coming from? All right. That, during angry episodes, is not the time to set the record straight. I did not. This, you did. That is not the time to set the record straight when someone's angry. You say never argue with someone who's drunk, right? Would you get into an argument to set the record straight with someone who's drunk? I hope not. So don't do it with someone who's angry. It's the same kind of thing. They're two different people, but they're not thinking clearly. All right. Okay, that's it. See you Friday at 10. I will be here with a bright, shiny face. Friday at 10. Friday at 10. Are you hungry? Oh. Oh my gosh, this is how last month. Not ever. It could be any of the others. Thank you.